one. To be honest, of all the talks I have during this conference, this is the worst. Because when to stop ECMO is a very simple answer when it doesn't benefit the patient anymore. Yeah. Okay, let's go home. Yeah. But if you then look at the logistics and you take into account the cultural difference, that the previous talk was great. If you're on ECMO in Israel and it's not benefiting you anymore, you're in trouble because they won't take the ECMO out. Charlie Sprung had a brilliant solution for patients on a ventilator. I mean, shut the ventilator down next morning at 9 o'clock. And then you have a different situation, because if the ventilator shuts down, you can decide not to start again. And that's something completely different than shutting it down. That's not possible in ECMO. And so it's extremely difficult to, when the doctor or the team, it's never the doctor, it should never be the doctor, it's the team that decides that ECMO is no longer beneficial, then what? And that's a much more
what modern medicine is capable of doing is almost what 20 years ago was considered science fiction. Essentially, you can support pretty much every body system for years, because you can keep their lungs breathing and keep their heart beating, keep their blood pressure up and keep their blood flowing. That suspended animation state goes on forever. And so the decisions at the end of life have become much more complicated for everyone involved.
And so this is the phase where, I mean, you see a ventilator and you see a renal replacement therapy. This is a somewhat older documentary. Now we have them on ECMO, and then you're even in more trouble. And we go to great length with ECMO patients. I mean, we walk around with them. And so it's typically patients that are awaiting lung transplantation. And so they're in a reasonable state. I mean, this guy is biking in his bed, he's maintaining his Facebook page, he's WhatsApping with family, he's walking around in the morning, and some we even take outside to enjoy the sun on ECMO machine. But what about the point where you say, well, I'm very sorry, we're not going to do a lung transplantation in these patients, sitting outside in the sun? Because then you have a patient on a let's say, life-saving device, because you could always argue whether a ventilator is really maintaining, and you could do extubation and hope for the best. But in ECMO, it's simple. If you shut down the ECMO machine, the patient will die. And so how to deal with this? That has nothing to do, and it's much more difficult than when to decide when ECMO is no longer beneficial. So that's a very difficult question. And a very difficult circumstances. It's probably one of the worst situations you can end up as an ICU team. And of course, the objectives have completely changed from saving lives with reversible condition. We now change to, when I wrote the national guidelines in the Netherlands 15 years ago, which are still valid, we facilitate recovery of a organ dysfunction or failure, whatever it is, to a level that results in discharge from the hospital. At least in the Netherlands, if you're bound to a hospital, that's the end. We don't treat you to remain in a hospital. And ECMO, of course, for a lung transplant patient where there are no lungs, or we won't transplant lungs, that's destination therapy and destination ECMO in the ICU. That's unacceptable. Because if you're on ECMO, someone else cannot be on ECMO. And so it's not only your life, but you're also influencing other lives. And the question of benefits is something I will come back to in a minute. So the moral framework, I think, for intensive care treatment in general, and I think to the worst extent is ECMO, is do well and do no harm. I think everybody agrees. Now, the question is, if you put a patient on ECMO, while he won't benefit because you're sure after a few days or weeks that there will be no lungs, there will be no heart, he cannot have an LVAD device, and so basically you're in destination therapy for ECMO, is that the point where you're starting to do harm? Whenever I bring this up in New York during my rounds, they get completely confused, and most of the residents and fellows start crying because they have no clue what to do with, okay, so basically I'm harming a patient here. The other one, and that's discussed in the previous as well, is respect for autonomy. Is the patient really in charge? Is the patient really in charge? Like, no. I mean, you can do whatever you want, but I stay here. And that's extremely difficult. If you talk about, do you want a hip replacement with local sedation, local pain relief, or do you want complete anesthesia? Yeah, well, I mean, ask the patient. But do you want ECMO? I don't think that's a valid question for a patient. And so autonomy gets a really different perspective. And if you ask a person from Turkey, do you want an ECMO? They say, well, you're the doctor. I mean, I'm not the doctor. You decide. And so it's cultural. And there is a real, let's say, ethical problem. When you go to the extremes, we take over your life with an ECMO machine. And then, of course, and that's even more difficult, do justice. If I don't stop ECMO in this patient who will not benefit anymore because there is no way he or she will get out of the ICU, the one that could benefit in cardiac arrest with pulmonary embolism in the emergency department cannot come to my unit. Of course, we can transport them. We put them in New York, we put them in an ambulance or in a plane, and we transport them somewhere else. That's probably associated with some harm, at least something that we cannot really measure, but it's, I mean, you can imagine that that's not, probably not the optimal situation. And so doing justice when ECMO is no longer beneficial is extremely difficult. So Gordon Rubenfeld, a long time ago, talked about the principles of withdrawing life support, and this is almost 15 years ago. And he said, well, the goal of withdrawing life-sustaining treatments, including, well, not at that time he was thinking about ECMO, it was more about mechanical ventilation, is the removal of treatments that are no longer desired or do not provide comfort. In this time frame, that's irrelevant. We are not here to provide comfort. We're here to provide a life-sustaining treatment while the patient is comfortable. And so comfort is something that is normal. Every patient should be comfortable, whether you're aiming for A or aiming for B. So a treatment that does not provide comfort because you can't, but it will save his life is much more acceptable than a treatment that won't save the life, but the patient is comfortable. So actions whose sole goal is to hasten death are morally and legally problematic. Well, removing ECMO is just that, just as LVAD devices. And finally, the last one, the circumstances justified withholding one indicated life-sustaining treatment. You should strongly think about removing the others as well. That's, I mean, in the Netherlands, that's something like, what? So you stop renal replacement therapy, and you know the patient will die because you don't exchange the pH anymore, and then you wait for cardiac arrest and keep him on a ventilator? What are you doing? And it doesn't make any sense. But in a different culture, it can make perfect sense. And that's, of course, very difficult if you have a doctor from one culture and a patient from the other culture, which is both in New York and both in Rotterdam common practice. Now, the group in Colombia is doing a lot of ECMO. Basically, we already now have one unit with only ECMO patients, mostly VV ECMO. It's in the medical ICU. And so Daryl and Dan Brody wrote a lot about the ethical problems in these patients, because there are a lot of ethical problems. And if you look at this one, number 3, when a patient is begun on ECMO, and that's what we're talking about, when should you stop ECMO, the doctor-patient relationship evolves into a closer emotional and ethical bond. I'm sorry, but that's not true. The ethical bound and the emotion should be there from time zero, and not when he's put on ECMO. There's hardly, I mean, I have no emotional bound with the patient in cardiac arrest that you put on ECMO. The patient doesn't talk anymore. So you have a bound with the family, completely different. But you have a responsibility to the patient. So this is not something that evolves over time. I mean, you might evolve over time that you don't like the family of a patient. That happens. And you might not even like a patient. But that doesn't mean that you don't take care of them. And the other thing is the only reason to even consider removing ECMO. So removing ECMO is basically a no-no at Columbia. From the objecting patient is in case 2, as opposed to the patient with cancer. So a patient with cancer that you give, let's say, treatment that doesn't go anywhere is much more difficult than removing an ECMO from a patient that doesn't want you to remove it. Well, the context is completely different, but the problem is the same. I think that giving patient cancer, and there's this great documentary about the hospital in Los Angeles, where they offer a clearly dying patient. I mean, we as intensive care workers, and we look at the patient, we say, okay, he's dead tomorrow. And then offering chemotherapy, like you have a choice. You could do chemotherapy, or maybe you could go to hospice. In our understanding, that's absolutely harm. Just like if you go to a patient and he said, well, we just had a conference, we decided to remove the ECMO, and you take the lines out. I mean, that's not good as well. And that's what Daryl and Dan was referring to. They think that in some cases, especially in the Netherlands, we go to a patient and we said, well, we had this conference and we don't think it will benefit you anymore. So it's now, it's 6 o'clock, so at 7 we will remove the ECMO. I mean, that's not how it goes. That's not how you do it. So that's not really the case. They wrote another paper, Understanding the Ethical Decisions for Patients on ECMO, and they said discussions with surrogates must consider autonomy in decision-making, and yet pass the fine line between therapy with a goal, cure, go home, or a device merely preventing the dying process. Well, this will never help you at the end of the day, because you cannot respect autonomy if you decide that ECMO will not benefit the patient anymore, or that he's, let's say, causing a problem down the line for other patients where you cannot do justice, or where you're basically doing harm because you maintain an ECMO that will eventually lead into the death of the patient. And so if in these cases you have to consider the autonomy of the patient, the answer of the patient will be, well, I have only one, oh, it's gone. So if the objective of the patient is not being dead, you're lost. The end of the discussion. And if you really talk to your patients on ECMO, and we did a lot of withdrawal of ventilators in awake patients, the fear that drives not to remove the ventilator is the horrible dying. And once you, let's say, get rid of the fear of dying, and you confront them with, do you want to be on a mechanical ventilator at home? And they say, no, absolutely not. Well, I mean, then there is only one way out. We even had one patient who said, okay, yeah, now I get it. And I completely agree, but you mean, the Olympics are starting tomorrow. I love sports, so would you allow me to see the Olympics? And we said, yes, of course. So for 3 weeks, we watched the Olympics together with her, and after the closing ceremony, she said, so, okay, now I'm done. So please sedate me, remove the ventilator. And she died after the closing session. So when to stop a life-preserving treatment? If you ask doctors, in general, in the survey that they did by Dan Brody, more than half of the doctors says yeah. And in this case, where this is so closely related to maintaining life, there should be a way where the doctor says, okay, this is it. That doesn't mean that this is it and in an hour you will die, but this is it. In some time from now, we will stop this treatment. And so it's in complete unbalance with the recommendation to respect autonomy and stuff like that. And others even said, well, I mean, VA ECMO, that's a quite expensive intervention, and so maybe we should save money. And patients who won't or are not likely to benefit, we should not even offer it just to save money. When we calculated the cost of VV ECMO and VA ECMO program for the board of directors in Rotterdam, they came with these crazy numbers, and we said, well, let's look at the incremental costs, not look at the cost of having a patient on ECMO in the ICU, because that's probably not very different from having a patient on a ventilator and renal replacement therapy. And we came with the incremental cost. So how much money more do you need to do ECMO instead of the other stuff? That's about $2,500. So that's not a lot of money. So costs as incremental cost is, I think, the wrong objective. So when should you stop? In general, ECMO or no ECMO, when the treatment is disproportionate. When the intervention you do to the patient, the harm that you necessarily do to the patient, I mean, ECMO is not, let's say, a small arterial line. That's a big tube into your femoral vein and into your jugular vein, or an even bigger one only in your jugular vein. And so when the harm or the necessary inconvenience that you do to the patient don't outweigh the benefit the patient will receive, then your treatment is disproportionate, and then you should stop. Because from that point on, you're harming a patient without benefit. And there are other cases as well, of course, if it's unlawful. If the patient doesn't want ECMO, you can say, well, I mean, and then put on ECMO. That's impossible. If the patient, of course, is conscious and reasonable. Able to make a decision.
Jan, will you come to two minutes here?
I'm finished. And the other one is futile. And so if there is futility, we don't like the word futility, but if it's ineffective and pointless, it doesn't make any sense. A patient who is brain dead and doesn't want to be an organ donor, we decided in Rotterdam, if that patient is in the emergency department, the patient will die well, he's already dead, of course, but the patient will die in the emergency department. We don't take these patients to the ICU. That's pointless. Why? If family is on their way, it's different, of course. You take some time. Okay, and so addressing request of a patient, that's the final slide. So the patient wants something that is, in our opinion, not beneficial. Then Brett et al. Recently said, well, the physician should not provide intervention that do not meet the criterion. But again, in all of this, we should take the patient into account, and then it's, okay, what if it's not to be dead, and then you're in trouble. And so I think the system that we operate in should be based on solidarity and justice, also in ECMO. And the healthcare practitioners should be ignorant about the outcome. It sounds a little bit harsh, but basically we should not care what the outcome of the patient is while taking care of the patient. We should do the best, and the result is an outcome. And I think when empathy takes over, solidarity and justice are out. Emotional empathy is contagious. It's very common in the US, drives a lot of help for bad systems. Cognitive empathy is good. I recognize that you suffer, but I still watch Netflix tonight and have a good meal. That's cognitive empathy, and I think that's good. And ECMO could be based on the organ donation system, where we deal with, let's say, the inability to give everyone organs, and to limit transplantation in patients that do not benefit. Thank you very much.